1866, some very creative surgeons started by trying to localize lesions they saw on mammogram that they were not able to feel. And they started by just placing a bent wire down under fluoroscopic guidance through the lesion, and then took the patient to the operating room following that wire. With time and over the next decade, they were then able to improve this to something very similar to what we have used for many years now, by combining not only the wire, but then the wire with a hook to keep that wire in place. It kind of lodged it in like a fish hook so that it wouldn't come out while they were transporting the patient, etc. Next. So wire localization historically has a lot of variety to help us reach many lesions. The wire length can be anywhere from a short wire of 3 centimeters to 15 centimeters. It can be an introducer that's quite thick or quite small, thin, anywhere from 16 to 21 gauge. The anchor, we've used all different varieties of anchors, hooks, barbs, pigtails that kind of keep in place, all to kind of help manage the different types of breasts and to keep these wires in place so that when we go to the operating room, they are in place. Many times after placement, we then take a mammogram so that we can kind of follow the map as you were with the mammogram to follow and confirm placement of where that wire is compared to the lesion. And then, of course, the patient comes out with a long wire outside their body, and so this is covered or taped to protect its position. Many advantages of wire localization that we've all had in our practice through the years. It's very safe. There is very minimal, radiation. There is minimal issue with any of the device because it's just a wire with a needle. You put the needle in with the wire and then you pull out the needle, leaving the wire in place. So the safety of it has been used throughout many, many years. It's very cost effective. We don't need any monitors to put it in. We don't need any monitors to take it out. We don't need any devices to check them or to make sure that they're working. There's no batteries. So the cost effectiveness is very, very advantageous with wires and has been through the years. It's very well established. Practices around the world have used this for many years, and it's very versatile. You can get a mammographic lesion and place a wire by mammogram. You can place a wire by ultrasound if that's easier for the patient than to go through a mammogram. And there's even MRI compatible wires that can be placed with MRI guidance. There are, however, disadvantages that we have put up with through the years, but thankfully with our localization techniques now, we no longer have to put up with these disadvantages. I'm sure we've all had cases where some of these things have happened, and then we're in a bit of a position in the operating room where we don't really know, and we're kind of trying to make up for some issues that we're having. So as all of you know, depending on the breast shape and size and just kind of the process of getting the patient to the operating room, wires can be dislodged or can migrate. And so when the patient is prone in an MRI machine and has a wire put in and then changes position to come to the operating room, that can migrate the wire very significantly. if the patient has a very pendulous breast, and we put it in with mammogram. And so we put the wire in, it's a hard localization, and we get the wire in the place that we want it. And then we take the patient out of compression, and the weight of the breast pulls down, and then the wire migrates further than we want it to. I had a patient who also went downstairs to radiology in the morning of her surgery, had the wire placed. It was very difficult because it was under the breast. And so they worked very diligently to get a good placement. We took the patient up to pre-op holding, and as she was sitting there waiting for her surgery, she got cold, and so her family member helped her put on a sweater that then pulled out the wire. So she had to go back downstairs for another wire, which we've all had those stories of these wires dislodging. They can also be fractured or transected either before or during the surgery. As you know, we trim this long wire off, and sometimes if we have a new nurse in the room or somebody, they may trim it too short, and then it kind of migrates down into the skin and you have a hard time finding it. Or electrocautery can actually transect the wire as we're dissecting down into the breast. All of which is very disconcerting and difficult to handle. And also just locating the wire. If it's in a difficult location or it's not the best placement, having to transect the whole breast to get over to where it ends and the lesion is, it can be very difficult. Or if the lesion is kind of not exactly at the tip, we have to kind of estimate the distance from the tip or one of the dots to the actual lesion. So those are all things that can be difficult with wires. Next. Also, just timing. We've all had these issues with wire localization. Normally, it takes place the same day as surgery, which leads to kind of scheduling conflicts between our radiology colleagues and the surgeons. Their day is busy doing images, and so they may have certain times that are set aside for procedures, which may not really line up with the surgery schedule, and vice versa. There may be openings in the surgery schedule, but that doesn't allow enough time for the wire to be placed. Even now, with a lot of surgery centers, the wire has to be placed in locations different from where the surgery will occur, and so the patients are having to be transported, and you're doing the logistics of two different hospitals or locations for surgery. Also, delays in wire placement. The patient before them in radiology had an issue or it was a difficult case, and so that's pushed back. So then that pushes back the operating room. Delays in transporting the patient. The patient may need to go from one place to another and may be anxious about that, waiting for family members to transport them or whatever the process is at your facilities. Also, really lack of flexibility. You can't do first case of the day when first part of that case needs to be in radiology, and we need to wait for that staff to come in and place the wire so that we can. So when we used to use wires, the first case that I could do with a wire was 9 o'clock instead of the 7 o'clock to give enough time for them to place the wire on the day of surgery. Next. Also, just anxiety. This all occurs at the same time. The patient's being moved, they're nervous, they're told don't move, don't touch, and they're just kind of sitting there still waiting for their surgery because they're waiting for this wire to make sure it doesn't get dislodged. Our literature and our experience shows us about 10 to 20% actually vasovagal during placement. And I think that has a lot to do with the fact that they're already anxious because it's the day of their surgery. They've been kept without eating or drinking anything for several hours. And so they're in a position that makes them dehydrated and just more at risk for vasovagal, whereas we can decouple that with our localization techniques. Also, just long wait times. I always told my patients to bring a book, make sure they had something to do while they waited, because our timing, again, doesn't always match up. And so it could be several hours before the patient's surgery. And so they were just sitting, waiting, thinking, and getting anxious. And also, again, just the concern that they have for this wire being pulled out. Next. So that got us to going wireless and all the advantages of our localizer with Hologic helps mitigate against many of those frustrations that we have. And it's been a wonderful conversion for our facility and our patients. And so I just want to share about the equipment and some stories and cases about how we've used this and some tips of what I've done in my practice to help start this journey with Localizer. So the placement, again, is very versatile for those lesions that you can only see by mammogram. It's very straightforward to place by mammogram. This is just an example of the trocar that then deploys the clip. And so this can be placed by mammogram, and you can see on the mammogram picture here, very similar to wire placement. And so you can put that in place, and it works very well, very similar. The learning process is very similar to wire, so that learning process for the radiologist goes very well. Next. We can also place by ultrasound. As you can see, it's very visible by ultrasound. Again, similar trocar to put in the clip. You find the lesion and you just numb up that track and place that wire or the clip through with ultrasound and deploy the clip. On the right, you see the trocar coming into the lesion, and then on the left picture, you see that clip at the edge of the lesion where it's very visible by ultrasound, so you can confirm placement and make sure that it deployed correctly. It's very comfortable for the patient. They don't have to have a mammogram in order to get this placed, and so it works very well. Next. This is the device that we use, and I'm just going to go over kind of three main parts of this device. It's very small. It is the size of your iPhone. It's, just handheld device in the operating room. The reader itself is that box there, and it's battery operated. So there's no cord to attach it to any kind of charging device. And it displays the distance to the tag in millimeters. Each tag, which is a great feature, which I really like, it has a unique ID tag number that displays on that screen. And so when you're hovering over that tag, you can see what clip number it is, and that unique ID is then displayed on that in the operating room for you. And I actually have my radiologist in their dictation dictate what number they've used, so that then I can reference that, especially if we use more than one. That's very, very helpful. It's battery charged, and it has the signal strength is very strong. The tag itself is very small. It has, again, this unique ID number for each tag, which is on the package of the tag. It's encased with glass with an anti-migratory sheath. So once it goes into place, it stays. I have had several different cases where we have placed it many, many weeks before surgery, either in a planned way or an unplanned way. I had one patient who broke her hip right the day before surgery, and we had already placed the tag, and so we had to wait for her to get her surgery for her hip. And so this did not move at all through all hip surgery and recovery and physical therapy. It stayed in place. So it is very helpful to have that feature. And again, like you saw in the previous picture, and you can see here, it is very visible by ultrasound and X-ray or mammography. The detection probes, there's two main detection areas. So we have the loop probe, which is integrated into that reader. So that top little circle on the top of this little box is the loop reader. And that I use in a non-sterile fashion before I prep the patient to locate the lesion on the skin if I need to. Or once it's draped, again, before I make my incision, I often use the loop probe. Then there's the surgical probe. It's pencil size, and I actually have one here so you can kind of compare it to my finger. It's very small. The tip of it is very, very small, which is a great feature. I don't feel like I have to change anything of how I make my incisions. Several of the other techniques, this reader is quite a bit bigger, and so I've had colleagues who felt that their incisions have to be made bigger in order to get this in, and their instruments. And this I've been able to maintain very small incisions. It works very well right next to my instruments or next to my finger as I'm dissecting to use. And both probes, both this one and the loop reader on top of our box, are real-time reads. They're immediate feedback, and you can read it from any angle, and it's very, very helpful. Next. Just some of the features of these different things. So the tag, as you can see, kind of a very blown up version of it with the anti-migratory sheath around it. It's 9 millimeters by 2.2 millimeters, so very, very small. It's very robust. You can use electrocautery on it. You can use anything on it. You can try and cut it. It's not going to be injured or react. It will stay right there. The different probes, the different readers, the loop reader, again, at the top of the handheld device, that loop, that little circle at the top, that reads up to 60 millimeters or 6 centimeters. The handheld pencil, which I usually use once I have the incision and I'm going in surgically, reads up to 30 millimeters or 3 centimeters. Again, that tag has its unique ID, which is very helpful if you have multiple lesions or bracketed lesions. You sense the tag. This picks up the distance, which is displayed in a very large number. So that number 14 on the screen is 14 millimeters. And you can also have an audio tone. As you get closer, it gets louder if you like audio feedback. The size of the reader is very small, fits in the palm of your hand. I actually use a little plastic pocket on my drape so I can have it right there next to me, so I can be operating and using this. I can still see my handheld probe right next to me with a pocket. It's very responsive. It's immediate. You don't have to wait for it to kind of read it. It comes right back to it. And there's no interaction with the operating room lights or with the electric cautery. Again, you can use the electric cautery right on top of it and it won't turn it off. It's still readable. And it's visible again under ultrasound and mammogram. It is visible under MRI. It has about a 2 centimeter bloom around it, but that really doesn't affect the rest of the ability to visualize the breast. So if you're using it post-neoadjuvant, you can still see all the other areas around where you have that clip. Again, one of the great advantages of it is just that very pencil-sized tip, and that conformation is built all into this device for radiology. Next. So this just kind of points out what you see on the reader and kind of the display. So at the very top, you can see a little line, and it's called the toggle probe display. So that either will be a picture, it's a little picture of a pencil like this right there on the screen. If it's a circle there in that location, that means it's connected to the loop probe. So you can toggle between the two readers. Again, the large number, which is very visible, is the distance display. You have a volume control, a power button, the tag applicator, which again is similar to this one that I have here, which we have lots of different lengths there. The loop probe is the reader at the top. It has displayed of the battery life, the audible, how high you have your audio set, and then the blue button toggles between if you want the loop probe to be what's reading the distance or the surgical probe, the pencil probe. And so that blue button, you press that and it toggles between the two. And then, of course, you can adjust the brightness. And then this pencil probe is connected to the device. Next. How does the RFID or radio frequency ID tag work? It has a signal on the two poles, and in this diagram, you see how the tip comes in and reads that tag. The strongest is when it's at this end, but it really doesn't, in the operating room, that doesn't affect how you can read it in any way. It's very readable, and I don't have a hard time at all finding where it'll read it. You don't even really notice that, but this is just kind of the physics of how that works. This entire white portion of the pencil picks up the tag. So if the tag is over here, or the tag is over here, or at the tip, it's going to read it the same way. So what I do is I kind of come this way and then this way and this way to kind of see where I have the smallest number, meaning I'm the closest to it. Next. So some of the advantages of wireless RFID guidance. Once again, we're able to control our surgery schedules and uncouple this localizing placement from surgery. So this allows for less stress the day of surgery. I essentially mainly, for the most part, schedule my placement about a week before surgery. That way, if I have change in my surgery schedule, I can move these patients around if I need to, and I know they already have their localizer placed. It also allows our radiologist colleagues, they can kind of bundle these in the part of the day that works best for their workflow. They're not having to have the pressure of, we got to get this patient downstairs to the operating room. That works out much better. Both departments really are able to then optimize their utilization and optimize their time in their departments to provide the best different procedures that they're doing. And so it doesn't kind of clog that whole schedule up for the operating room. And it's just less stress for the patient. They don't have to come hours before and sit and wait and be anxious thinking about their operation. Less surgical time. You know, sometimes when you're following that wire, you're not sure where you're going, you're looking up at the mammogram, you're following it. This, as soon as I prep the patient, I have that device, I can plan where my incision is. And as I'm operating, I use the pencil and I go straight to the lesion where I need to know. And there's continuous feedback as I go and get closer. And so that really has decreased surgical time. I will say, if you have residents, this is an amazing technique. It really is a steep learning curve to teach residents how to follow the wire, and even just you really have to have that 3D ability to read mammograms and where is the wire and where is the lesion. And with this, it's really much easier to show them, and as they're operating, they can follow that down. So my residents have really, really appreciated this technique also. And just less volume of resection. You know exactly where you are. You know you're 2 centimeters above it and then 1 centimeter above it. So you're going to start going around the lesion. And so you have constant feedback of where you are in millimeters. So you can take less tissue, but more appropriate tissue. One of the great things about that individual identification number for the clip is that you can use more than one clip. We usually like to have them about 2 centimeters apart, but bracketing calcifications, multiple lesions that you want to remove. Again, our practice in our facility is to have the radiologist document, you know, the number that is the anterior clip and then the number that is the posterior clip. And then I know, oh, I got to the anterior clip and then I'm at the posterior clip because I see that number with the distance in millimeters right next to it is the ID number. And so I know which one I'm looking at. Also, the ability to do office-based procedures. You can place this by ultrasound on your neoadjuvant patients. And you as a surgeon can place it yourself with ultrasound in your office and position the clip exactly where you want it. And you know when you go to it exactly where it is. So it is very useful in the office as well. Next. Other advantages, there's no regulatory requirements. You don't have to have special requirements that you have to make sure your staff is signed off on. There's no special handling or disposal of it. It is just radio frequency with glass, so it's not anything that you have to make sure that your OR is educated in. There's no restrictions of what kind of surgical equipment you can use with it. I use all different types of lighted retractors, electric cautery, photon blade, plasma knife. They all work with it. The OR lights do not interact with it in any way. There's no big monitor or device that you need on your with your electric cautery to hook it up to. It's just the one little box. There's nothing else that you have to have to connect it to. For those patients who have nickel allergies, there's no nickel in it, so it's really non-reactive to the patient, so you can leave it as long as you need to, months and months. The pencil probe is completely disposable. You get a new one for each case. The cost is very advantageous. The MRI balloon is very small, and it really doesn't block your ability to see the rest of the breast, or the axilla, or whatever the area that you're using it in. Next. So in the operating room, I always encourage my residents and my colleagues to display the mammogram. So we take a mammogram after we place the tag, so that we can see where the tag is in relation to the lesion that we're trying to remove. If you have a large lesion, it's important to know if the clip is on the side, in the middle, in front, up, where according to the lesion it is. And it just, again, gives you another sense, another ability to know where you're going. So I always encourage you to display those in the operating room. Next. This is in the operating room. This is my scrub tech getting the device ready. It comes with a plastic cover, and so they just kind of hold it up. It's kind of like an ultrasound cover, essentially, and they just place the reader into that cover and wind up the end, and then that white strip comes off and it tapes down very well. Then you can use the buttons through that plastic drape very easily. You can see the monitor very easily. It does not obscure that ability to visualize in any way. Next. Then at the very top of the reader, there's a little hole where you plug in your pencil probe. So this part is the disposable part. And so there's a little tag and you just take it off, and then you put the little pencil probe, the little plug here, you just plug that in. And so then you're able to use this in the operating room, and it works very, very well. And there's no wires attached to this. It's all there. There's not a cord that is attached to anything. This just kind of shows you kind of what I do in the operating room. I prep the patient, and I will say when I started, I did this actually also before we prep the patient, but now that I'm a little more familiar with it, I have my mammogram displayed in the operating room. We prep the patient, and then we take the loop reader, again, that circle reader at the top. And you can see on that display right next to the 53, there's a circle. And that circle means that you're on the loop reader, meaning you're on that reader at the top, okay? So then you hover that circle over the breast, and I would do it in kind of a crosswise fashion like this as you go around the area where you know the clip is, and find the smallest number in millimeters. At the smallest number, that's where your clip is. And so then I mark this area so that when I start the operation, I know which direction I'm going. Once I mark the area, then I can decide where I want to make my incision. We try to hide our incisions. We try to be very cosmetic and appropriate to our oncoplastic techniques. And so depending on where this clip is, then that will help me determine where I'm going to be making my incision, and then kind of plan my oncoplastic techniques around where I make my incision and where I'm going to be removing my lesion. So you can see this X locates where that clip is, and then I make my decision on where my incision is going to be. Next. Once I make the incision, and here I decided with a periareolar incision, then as I get closer, I use this probe, I use this pencil probe, and I'm then putting this in, and you can see initially at the skin, the number on the screen was 53, okay, because the loop probe goes up to 60 millimeters or 6 centimeters. Once you use the pencil probe, you are closer to it because you're heading that direction. And so then as you head closer, you see that number getting smaller. And I don't know if you can see because of the light kind of on the screen, but next to the 33, you have a picture of a pencil, which means you're on the pencil probe. So you know that's what's reading it. And then you see the number 33, and then you go down towards the lesion. As you get closer and you're at about, 20 or 10 millimeters, depending on where you want your margin, then you can start going around your lesion and coming around. And then as you're kind of pulling your lesion out, you can continue to make sure that from the medial and lateral margin, posterior margin, you're still that far away from the clip that you want to be. Next. There is a learning curve, as with anything that we use that's new. I will say the learning curve on this is very small, both for my radiology colleagues and my operating room team. It's worked really well. I will say probably the first maybe 2 full operating room days of using these. My radiologist put both the clip and the wire in, so I could kind of get used to the change between the two techniques, and the mammogram would then show both, and I could kind of start to bring my mind around, just switching how I thought about things. And so that was very helpful, but I didn't do that for a long time. It really became very straightforward. Then once we stopped using the wire, the radiologist, for just maybe a couple cases, and I think it was more for their knowledge than mine, they just marked the skin of where they put it in, and then I knew where to kind of start looking as far as where the smallest number would be. So those were 2 techniques that we used as we were starting out that really helped. I will say with my residents, they use wires at another facility. And so they come here and they have a very quick pickup of this technology, and it's really easy for them to understand and visualize. And they, again, really like this technique. Next. So I'm just going to go through a couple cases that kind of just shows a little bit of how we use this and some of the techniques and tricks that I have learned through the years on using this. Our first case is a 73-year-old female. She had a left invasive ductal carcinoma at 10 o'clock, 10 centimeters from the nipple, 1.6 centimeters in size. Next. You can see here the mammogram after the placement, and you can see the radiology clip first and then the RFID clip. They're very close proximity there and good location. Next. So again, we start with the patient in the operating room. This is her left breast. We then use the looped probe tip to find where that lesion is going to be. It actually is, that is actually my initials from marking the patient, but it's actually right in that area also. But we mark that area, and then again, I can make my plan for where do I want this incision. So I'm not kind of guessing where I am. I'm able to go straight there. And make my incision. And again, in this case, we decided with a periareolar incision. And so we were able to make our incision there and then head straight up to the lesion, excise that. And again, this pencil is so small and it's a very nice length that it's not hard to get to the lesion. I have enough length that I can see. So even from this distance on this case, it was very easily used to reach. Once I made my incision, I was able to get up to the lesion and excise it. Next. So this is our mammogram, our specimen radiograph of our lesion. You can see the lesion with excellent margins, our 2 clips, it just was a very successful operation for this patient. Next. Our next case is a 74-year-old female with right invasive lobular carcinoma at 9 o'clock on her right breast, 5 centimeters from the nipple. And it was a 3 centimeter area of microcalcifications. Next. So in this case, we decided to use our clips in a bracketing technique, which works really, really well. And so essentially they place them just like they bracket wires. And again, we have our radiologist colleagues. The number is on the packet when they place the clip. And so they then dictate the number according to which one, whether it's medial, lateral, anterior, posterior, superior, inferior, however your bracket's occurring. That will help you identify which clip is which, so you know where you kind of are, and you're thinking that spatially. And so we have that on our dictation. We can see that here on our pictures, and then we go to the operating room. Next. So here you can see that we decided to do a radial incision. It was quite close to the skin, so we wanted to take a little bit of skin with this case, and you can see the 2 little areas where the clips were. And so we were able to just go right through and take out this area of microcalcifications. Next. And again, you can see here the biopsy clip, but then again, you can see those 2 bracketed clips, which work really well. They work best if they're at least 2 centimeters apart, then they don't get their signals crossed. Sometimes when you have an anterior posterior, you will read the anterior number first, and as you pass that, you will read the posterior number, which still works very well. It doesn't block the numbers, it just will give you the one that you're reaching first, and then the next one. And our last case is a 61-year-old female who had neoadjuvant for right invasive ductal carcinoma. She had multiple lesions, 2 adjacent lesions at 10 o'clock, 9 centimeters from the nipple and 10 centimeters from the nipple. So these were just 1 centimeter apart. And then an indeterminate lesion at 9 o'clock, 9 centimeters from the nipple that we also wanted to remove. In this case, I used the tags after her neoadjuvant. So we placed them after her neoadjuvant. We had surgical clips or biopsy clips placed in her initial diagnosis. She went through chemo, and then these were placed after chemo. Next. So you can see the one circled with the yellow is the lesion that's indeterminate that we need to remove. Sorry, the one in the yellow on the right screen. And then the posterior one was the blue, were the 2 surgical clips. You can kind of see those 2 clips right next to each other. So we actually used just 1 tag there. If they had been further apart, I would have used 2, but I felt like if I went straight to the pec, anyways, I was going to get that posterior one. So I didn't feel like we needed to deploy a 3rd one, but you could if you wanted to. Next. So we took the patient to the operating room. We were actually able to make this incision kind of on the lateral breast. And we actually got both of these, or all 3 of the lesions actually, through the same incision. So essentially what you do is you'll go up to the one up at the top and get out this lesion, and then you'll go down here and able to get out through the same incision. So the patient got 3 lesions out through 1 incision. And she looked great. Afterwards, we were able to get good margins, and she was very thankful to be able to have breast-conserving surgery. Next. So here you can see the indeterminate lesion with the 1 clip and the 2 adjacent lesions with the single clip kind of between the 2 biopsy clips. Again, she did very well, and 3 lesions out with 1 incision. We were able to go both directions because we knew which number those IDs were. We had that unique ID number for each tag, and so we were able to know which one we were going after. Next. So thank you for the opportunity. I hope now we can have lots of time for questions. I know everybody's practice is different, so I'm happy to answer questions and go through how I can help you with my experience. And I think Sudeep will go through the questions.
Thank you so much, Dr. Gorman, for that insightful presentation and actually introducing us to the components, functionality, and workflow on the wire-free RFID guidance system. Great. So we shall now move on to the question and answer sessions, which will be managed by my colleague, Ayan. So Ayan, over to you.
Thanks, Sudeep. Hi, everyone. Thank you for attending today's webinar entitled A Revolution in Localization. For those of you who have any questions, kindly type in your questions in the Q&A tab, and we will try our best to answer them within the next 10 to 15 minutes or so. So my apologies in advance for those questions left unanswered given the time constraint, but we will collate them and get them answered after this webinar. So before I present the first questions, I'd like to just summarize the key messages from the presentation, and that in essence, wire-free devices like the localizer can undoubtedly and easily improve workflow, provide clinical efficiency, and most importantly, provide a better patient experience. So the localizer has provided many benefits like anti-migration properties, increased precision with its unique RFID tags, and that helps with identification and maximizes surgical schedule flexibility, further revolutionizing the practice of localization. So Dr. Gorman, our first question is, with the use of the localizer, you mentioned that it has helped mitigate many frustrations, like reducing patient anxiety, which hugely helps with the clinical management of the patient. So how long was the transition before you decided to go wire-free? And does this mean you no longer use wire localization in your current clinical practice?
Yeah, so I don't use wires anymore. I probably, the conversion was very quick. My radiologists were excellent. They felt like there was no difference. They're like, well, I just either deploy a clip or I deploy a wire. It was very much the same process for them. They did not feel that there was a huge learning curve in the radiology department for placement. We probably did about 10 cases just with wires and clips, and then converted to clip only. And I felt I probably didn't even need 10 to do that, frankly, but you just don't want to get in there and not know. But it was very, very straightforward. So it just took a couple weeks to get through that transition, and we never went back. I mean, we just don't place wires anymore. So it was a very quick transition.
Thank you for that, Dr. Gorman. Okay, so next two questions we have is from Madhavi Chandra. So first question is with regards to the cost of the RFID localizer versus the traditional wire localization techniques. So how different is the cost?
Well, I mean, obviously, different costs around the world are a little different. In America, the wire is very minimal for its cost because you just have a wire with the guidance kind of needle that you put it in through. But the problem with that is that it takes quite a bit of time from the radiologist that day of procedure. And so they're not able to separately bill for their time. It's all included, it's bundled in. And so the real advantage of this technique is that because we can place it at any other time, it unbundles the payment. And you can actually get paid for the time of the radiologist placing the tag, plus the surgeon doing the surgery on the day of surgery. So because of that unbundling, we don't have that problem. And we also unbundle the mammogram. So we can, do the clip placement and the pre-op mammogram and then charge for the surgery the day of. Whereas when you use the wire, the radiologist just has to place it because it's all bundled together because it's the same day. So that is the huge advantage cost-wise. You do pay for the clip, and then you pay for one disposable pencil probe per case. but that device is reusable and it's battery operated, so there's nothing else to upkeep in cost. And the cost of that handheld reader, which is essentially, instead of some of the other localization techniques, have a big monitor box that you have to keep on your, back table, like another table or your boom or wherever you put it. And that's quite costly, whereas the handheld reader is much less of an initial cost, which is a great thing for me. I don't know about y'all, but it's hard to get our hospital when the initial cost is a lot, because then it has to go through capital, and this is, because it's not that huge cost, it ends up being a much more doable transition for our hospital. It really worked out well. Mm-hmm.
Thank you. Thank you for that clarification. So the next question is, if there is a maximum recommended lag time between tech placement and surgery?
No, you can place it as much in advance as you want. So the hesitancy some of our radiologists have when we have outside facilities is they don't know which surgeon the patient's going to go to and what's going to happen with them. And so we don't usually place it initially, although if we know that the biopsy is very suspicious and we're going to take it out, and we know it's going to be cancer, we know it's going to be removable no matter what, we'll go ahead and place it the first time. But if not, usually a biopsy clip is placed and then we come back. But we can place it pre-neoadjuvant. Most of the time I do it later, but that's just my workflow. But I have placed it, especially interestingly with COVID. We were, of course, on no elective surgeries. So we had a lot of patients who we had placed on endocrine therapy during that time where we couldn't operate. And so we actually had them go and get their tags so that as soon as we were able to operate on them, we would be ready. So there is no limit to how long you can leave it in. Again, I kind of told you the story about the patient who had a hip fracture the day before her breast surgery. So we put her on endocrine therapy, and she actually was a couple months out because of her hip issue. I've had other patients with other issues that have delayed a week or two, and it's perfectly fine. It hasn't moved at all. I have never, knock on wood, but I have never had one migrate away from where we put it the first time, no matter how long that time is.
Thank you for that. So the following inquiry is from CSUCAC, who would want to know if the localizer is used for patients who have neoadjuvant chemotherapy before surgery, and if it's removed during surgery. So do correct me if I got the questions incorrectly, but this reminds me of one of your cases. But Dr. Gorman, do share your thoughts.
Yeah, so normally my workflow is put it in after neoadjuvant, but you can put it in before neoadjuvant, absolutely. Depending on what you want to see on that MRI. So for me, I don't mind putting it in before chemotherapy because really what I want to know is my large tumors, my 6 centimeter tumors, that they're shrinking. If they're anything less than 2 centimeters, I'm still going to take that area out. I just want to know that it's not 6 centimeters so I can do a lumpectomy instead of mastectomy. And so that 2 centimeter bloom really doesn't affect me at all because I know that the lesion is underneath that. So I really want to just look at the rest of the breast. So that just is something you have to take into consideration, is that there is a little 2 centimeter bloom around it, but it still can stay in the whole time during neoadjuvant chemo. It works fine. It doesn't bother the patient. They don't notice it's in there, and it doesn't migrate. So it's a perfectly appropriate to put it in before, if that would be best for your workflow in your patient.
Awesome, thank you. So the next question, we have a couple of questions from Gloria. So her first question is, did you experience any migration due to the accordion effect after stereotactic guided placement? And if you have any suggestions on how to prevent it?
Actually, I think I've had less because it deploys before you let the breast out of compression. So I think when you have the wire, you're kind of getting them out of compression and the wire is still there, like hanging to the skin and to where you kind of hook it in. So I think I had more migration with my wire when you let go, whereas with the localizer, you're going in with it under compression, you're depositing it in the breast, and so it's staying put, and then you're releasing compression. So I think in many ways it has been less migration for me. So no, I mean, my radiologists are amazing. They're like right there. Whether it's a large breasted lady, very pendulous, very small breasted, I mean, whether they place it by ultrasound or mammogram, I think the localization and the closeness of the lesion to the tag is, I think it's a better localization. It's closer, it's more accurate than the wire was, because I think it deploys before you let go. So it's going to stay there. Mm-hmm.
Thank you. So the next one is, do you know if there's any contraindications for the use of the localizer? So it's similar to Suma Chakrabarty's question about, is there any risk with the use of the device? Like, for example, patients with pacemaker or metal allergies and things like that.
Yeah, that's great. So it's just glass, and so it doesn't react to anything. I have had no problems. There's no indicated contraindications, like there's no listed contraindications. It does not interact with any type of devices. So again, I've used plasma knife, photon blade, just normal electric cautery, ligature, all around this, and it has no effect to it. I think some of the other devices kind of turn off if you bovium, and then you're in the operating room without knowing where you're going, which is unsettling. And so, no, it doesn't react to anything. I have not had any patients, even the patients that have left them in for several weeks or months, have not had any reaction to them. There's nothing you have to be careful of. I've had it on. There's no patient I haven't put one in that I need one.
Thank you for that. So the next question is, will the hook wire, or basically any pathology or artifacts, can interfere with the signal from the tag?
No, there is nothing that interferes. I think one of the things that is a little bit of a learning curve is to realize that, especially on the pencil probe when you're operating, this whole white area picks up, okay? So you have to be kind of conscious of which side. So if this is my lesion and I'm coming close to it here, I will do this and I'll see like 14 millimeters, and then I'll come to the side over here and it'll be a dash, which means it's not even anywhere near it. So then I know I'm going in the right direction on this side. And so then I keep going down this way. But there's no interaction. It's immediate readback. I've not had any that have lost their signal. There's no interaction with OR lights or any other devices that we have in the operating room, which is great, because it just doesn't, I mean, it reads it right away. I don't use the sound because between the true node and this and, you know, the anesthesiologist music and everything is too loud. But I just look at the numbers, but some people really like the sound because as you get closer, it gets louder. So you can use whatever works best for you.
Thank you for that. So, is there a maximum depth from the skin for which the tag needs to be detected, or is there some limitations with that?
Yeah, so 6 centimeters for the reader itself. So that one reads further. So that's why you use that one before you cut. So that circle on top of the reader reads in a 6 centimeter depth. This one reads at a 3 centimeter depth because you use it once you get into the incision. And I mean, you're not going to go further than that from your incision anyways, because that'll be such a long traverse. So that's, it works well because then you can really plan your oncoplastics reconstruction and stuff around your lumpectomy because you know where you're going to have to make your incision and so forth.
Okay, can we take one more question? I think one last question would be, okay. So thank you so much. So how is this technique different from radio occult localization and excision using a neoprobe?
I think that I haven't used that other technique. My guess is that it doesn't have any interaction with other things. So some of those devices either interact with the light or the Bovie. And so your reads can be a little bit off or off, like literally non-existent. The other thing is there's no regulatory for the radioactive localizer. You have to have like the regulatory stuff set up in your department for placement and then in your department for removal, and you have to have follow-up of regulatory, making sure you're following those regulatory requirements, as well as disposal of that clip and so forth and so on. So this has nothing there. You don't have to have anything special. If you have when I was at a smaller facility where, I was doing a lot of my own localization, you don't have to have anything special. Like you can do it in your office and then you can bill for it. You can do it at the convenience of the patient when you want to do it. You can place it the way you want to place it. So it's exactly so you don't have to have any requirements in your office. And so that's, I think, just much less boundaries to get through as far as placement and making sure that everybody's following the rules.
Thank you for that. I know we have so much more questions left unanswered, but okay, I'm sorry about the time, but no worries. We'll collate them and we'll try to get them answered by Dr. Gorman. Sorry about that, Dr. Gorman.
Yeah, I'll be happy to answer them. Yeah, we'll get those back to you because it's really important to feel comfortable with what you're doing. I will say it just really was one step after another. It was very comfortable. There was no time where I felt like I was kind of out there going, oh, now what do I do, for my patient? Because I'm in the middle of an operating room with something I don't know where to go. And so I never had a case where I felt that way. And so it was really a quick learning curve. My radiologists really were happy and fine with it. They love the fact that they can bill for it, and they love the fact that they can put it in when it's good for their schedule too, instead of always having to follow where we wanted them to put it in.
So that concludes our Q&A session for today. So thank you, Dr. Gorman, once again for gracing us with your presence and sharing your insights on the topic. So thank you, everyone, for your active participation and questions.